Hello, welcome. My name's Rasha K. I'm from Imperial College in London, and it's my absolute pleasure today to present some discussions with Professor Sanjit Jolly about the Clear Synergy trial. We're here with you at AHA in Chicago in 2024. So, Sanjit, today you've had a really impactful day, 2 New England papers from the same trial, 2 very important stories around what we should do with patients post-MI. Maybe you can tell us a little bit about the results.
Yeah, so we randomized 7,062 patients, really early post-MI, to either colchicine versus placebo and spironolactone versus placebo. And we presented the results of the spironolactone factorial. And really there was a question, we know in patients with heart failure post-MI that eplerenone is beneficial, and that was the Ephesus trial, about a 15% reduction in mortality. But we don't know if people without heart failure benefit, kind of like ACE inhibitors. So we sought to answer that question. And what we found was for the primary outcomes, CV death or new worsening heart failure, or CV death, MI, stroke, or heart failure, there was no significant difference with the administration of routine spironolactone. We did see about a third reduction in a secondary outcome, which is heart failure, over follow-up, but the event rates were fairly low. And interestingly, we did an on-treatment analysis, and we did see significant benefits in the on-treatment analysis for both co-primary 1 and co-primary 2, so CV death or new worsening heart failure, or the broader composite. But I think this is hypothesis generating and can't be the primary conclusions of the trial. It was remarkable that patients did so well after an MI.
Yeah, so you've presented obviously 2 trials in a modern era, and congratulations for recruiting over 7,000 patients across the world. Maybe you could talk to us a little bit about the complexity of randomizing patients to 2 agents, both of which have their own side effect profiles, and how that may have impacted the results.
Yeah, so first off, I think Salim Yusuf has been the head of our research institute for the last 25 years and was always a proponent. If you're going to do the work, try to do two study questions, whether it's vitamin E and ACE inhibitors in the HOPE trial or some other thing. And I'm a believer that you really want to maximize that effort. The challenge, of course, is when you have 2 medications are harder for patients to take, and if you have one that causes diarrhea or some side effects, that can reduce your compliance or increase study drug discontinuation. So we really made an effort within the trial that if patients had diarrhea, couldn't take colchicine, they often stopped both drugs to try to reinitiate at least the spironolactone, if not reinitiating the colchicine even at a lower dose. And that was modestly effective, but it was a challenge. And it may have increased our study drug discontinuation, and that may have been a small price to pay. And perhaps factorial designs need to be a little bit larger to compensate for some of those effects.
Yeah, and so now I'd love you to talk to us a little bit about, we know the data within patients who have poor LV function, and obviously this was an all-comers population. Could you talk to us at all about infarct size, LV function within this population? Yeah. I know it was tricky to collect some of that data.
Yeah, we don't have measurements of infarct size. In terms of anterior STEMIs versus not, the interaction is not significant, but the point estimate suggests greater benefit for larger infarcts. We don't have reliable discharge or post-follow-up with regards to LV dysfunction, but that also may be people who have persistent LV dysfunction are likely the ones who would most likely benefit.
Okay, and how about the side effects from spironolactone?
Okay.
We saw lots of gynecomastia, obviously hyperkalemia. Do you think that would be an issue, and should we kind of be thinking about that when we see that in clinical practice?
Yeah. The rate of hyperkalemia was pretty modest. It was 1%, so it's pretty low. And it was higher, but it was still 1%. So I think 1% is very doable if patients needed therapy. Gynecomastia was somewhere around 2 or 3%, still fairly low. But I think that speaks to the potential of newer agents like finerenone who do not have those same side effects.
And do you think for us in clinical practice, what are you going to be telling patients? Are you going to say, and clinicians, are you going to say, base this on the size of the infarct? How are we going to take this evidence forward?
So I think the first thing is in patients with heart failure post-MI, there's data from the NCDR registry, the vast majority of those patients don't get MRA. And so we need to translate the prior evidence into practice, and this reinforces that. I think the second issue is probably the benefit is going to be in those patients. We know it reduces heart failure, but your baseline risk is very low. So if we can find populations who baseline risk for heart failure is high, those are patients that should get it. So we know patients who are likely late presenters, large infarcts with LV dysfunction, those who have subclinical heart failure, maybe an elevated EDP, but not, those are the patients that likely are high risk of developing heart failure and that I would use an MRA clinically.
Great, and now maybe I can bring you to that colchicine story while we've got you here and in the chair. Inflammation, there was a lot of promise around inflammation. We've had lots of conflicting data with different agents. We have new data, hopefully with newer agents coming up, very expensive potential agents. How do you feel about the inflammation story? Do you think there's more to come, or do you think it's time to just kind of throw that away?
What's interesting, prior to our trial, I was a big believer in colchicine, and one of the, two sizable trials showing benefits. And we were really surprised. In our trial, 7,000 patients with colchicine, we saw a reduction in CRP. CRP was very high, and then at 3 months, it was reduced more with colchicine versus not. We saw a doubling in the rate of diarrhea, about a 10% rate of severe diarrhea with colchicine, which is what we see clinically. But we saw absolutely no effect. So we saw no effect for the primary outcome of CV death, MI, stroke, or ischemia-driven revasc, which is a very similar outcome to the prior trials. And the on-treatment analysis was identical. Both hazard ratios are nearly 1, and we could not find a subgroup of benefit. So I've stopped prescribing colchicine in my practice for patients post-MI. And then one of the important issues, people say, well, maybe just in big MIs it doesn't work, maybe in chronic CAD. But our median follow-up was 3 years. Our maximum follow-up was 5 years. And so this was both an acute and longer-term trial. For me, I think we need to go back to the drawing board. Inflammation is clearly important, and maybe we need different pathways. I'm not so sure about colchicine. And then I think the final point is this is like an internal control when you have a factorial design. So the fact that we were able to see reductions in heart failure with spironolactone, but no effect of colchicine, despite the pandemic and the challenges, reinforces kind of the validity, internal validity of the trial.
Yeah, I think you've really summarised that nicely. For many of us, we hadn't really seen a lot of colchicine use post-MI. I think I agree with you that where inflammation should be highest and where the impact should be greatest is in this ACS population as opposed to the chronic space, and I guess we'll wait and see. But look, Sanjit, it's been fantastic to have you with us. I want to really congratulate you on 2 fantastic pieces of work. I also want to congratulate you for doing this in the face of your own personal tragedy with the loss of your father, and we really, he would be so proud of you today, and I'm sure the whole family are. So thank you so much for being with us today. Thank you so much for listening, and please feel free to go straight to the New England and read these papers today. Thank you very much again for joining us.